Okay, perfect. Welcome, everybody. Thank you all for joining us for this webinar on what they didn't teach you about expert determination and HIPAA. In this webinar, we will have some real-life HIPAA experts talk us through how the expert determination process works to de-identify health data, and what I hope you all really came for, which is a rundown on some of the pitfalls to avoid and tips to do it right. My name is Mark Unger. I'm the head of product management here at Datavant, and I'll be your host today. Today's experts hail from Mirador Analytics. Mirador will be joining us to talk about the realities of using real-world data, protecting patient privacy, HIPAA compliant, expert determination, and how to navigate all of this complexity. If you're here, this certainly isn't the first time you've heard of HIPAA. We know that. It is likely also not the first time you've heard of the expert determination method for de-identifying health data. But the Datavant and Mirador teams have both spent a lot of time deep in the details, figuring out how to make this work at the speed and specificity required by your business. And what we want to do is simply share what we've learned. We especially want to focus on the stuff that's not obvious until you're deep into it, or worse, you've made a mistake and you need to course correct on your project, or you realize you've dropped data that was important to you in your results. And that results in delays, a loss in data utility, and other headaches that we want to be able to avoid. We're inviting you to submit questions through the session today by using the Q&A function in Zoom on the bottom of your screen. We'll either address the questions that come in as we go, or more likely, we may come to those questions at the end in the Q&A section after the Mirador folks have finished the talk. At Datavant, we've been working with Mirador for years now as we help our customers to connect real-world data sets, and we often find ourselves explaining to customers that they need to consider these steps of expert determination, and then after connecting additional data sets that are de-identified, the combined data sets also need to be assessed again to make sure that the combination of data continues to meet the re-identification risk threshold. In short, there's a lot to make sure that you need to do right. To provide one hands-on example of this in action between Datavant and Mirador, Datavant was fortunate to partner with Mirador on the COVID-19 research database, which is a cross-industry collaboration to make real-world health data available for research on important questions related to the impact of COVID-19. And in order to pull this off, we needed billions of de-identified health data records from claim sources, EHR sources, mortality sources, consumer and demographics to come together. And all of that was only possible to pull off with expert determination process and expert guidance from Mirador to ensure that patient privacy was protected along this important effort. And Jamie will cover a bit more about this COVID-19 effort in his talk. Jamie and Colin and the Mirador team are experts in this field, and we've partnered with them on many projects in the past. To provide a brief introduction, Jamie Blackport is the CEO of Mirador Analytics. Before founding Mirador, Jamie spent more than 20 years at global pharmaceutical companies in commercial and medical affairs roles. So he's very familiar with the needs of the industry as it relates to using real-world data. And Colin Moffat is Chief Data Scientist at Mirador. Colin has 20 years of experience in statistics and data analysis. He's contributed to dozens of scientific publications and has taught applied statistics to university students at all levels. Colin is a fellow of the Royal Statistical Society with grad stat status. He holds a Master of Science in Data Science from Lancaster University, a PhD in Applied Biology from the Imperial College of London, and a Master of Research from Lancaster University. So Jamie and Colin, thank you both for joining us today. Without further ado, Jamie is going to kick us off by sharing his perspective on expert determination. Jamie, thank you again for joining us.
That's great, Mark. Thanks for the kind introduction. I think before we get going, I think one of the things we wanted to do is to have a quick poll from the audience just to get a sense for how familiar you are with expert determination. So if the technology cooperates, you should see a poll just coming up now. And if you could answer, that would be appreciated. Drum roll for the results, which is interesting and sort of as expected. So we've got some people who are really familiar. I hope that that's the case, but most people are somewhat familiar. And I think really that was the assumption as we built this presentation, thinking that most people here are looking for some insights or some secrets of how expert determination can be done better, or how to best work with an expert. So that's really what we're going to try and do in the presentation today. And I guess really what my role is to kind of set a little bit of a context before Colin dives deep into expert determination. But I think, I always think about this of, why should we care? So for me, my personal feeling is, my background is, I'm a clinician by background. I worked in drug development for many years. I also worked in the commercial space for many years. So for me, it has me excited about the potential and the necessity of combining health data together. But I don't think we have to look any further than COVID to see that as professionals in data or the pharma space or healthcare, that we really need to be better using every tool that's available to us to help individuals and society's medical needs. And I think really healthcare data, as everyone here who works in the space knows, that it's an incredibly powerful tool. But we also have a huge responsibility and a legal obligation to ensure the privacy of individuals. And this is where sufficiently de-identified data in the field of disclosure risk control, or more commonly talked about as HIPAA expert determination, comes in. Now, I think based on the familiarity that people have, most people will be aware, but there are some problems to solve with expert determination. Expert determination has historically been a bottleneck in the system, with few experts, frankly, taking too long to meet the needs of the data world. Therefore, our mission is not to be the bottleneck. I always describe this as the impossible mission by definition, because if you're the person checking, you'll always be the bottleneck. And so therefore, as a result, what we do is focus on and do everything we can to reduce time, working to ensure expert determination can be accomplished in the timeframes of days, hours, or even minutes, versus being measured in the historical context of weeks and months. But I think that's not the whole story, right? But completing expert determinations really fast is not enough. We need to ensure that the data is as useful as possible. And so, for example, we can be really fast by using broad approaches to preserve privacy, but as a result, there's a consequence and expense and utility. So our mission also is to understand the desired utility for use cases, and when completing disclosure risk analysis, make choices to retain utility as much as possible. Now, this requires a collaborative and flexible approach between experts and clients, and it's one of the things Colin will speak about. But I also think there's also some added challenges to solve in the fact that privacy is dynamic. And the question really is how do we ensure privacy keeps up with laws, changes in laws, but also the fact that data is changing all the time and readily available information is changing all the time. So how do we help ensure privacy occurs in that situation? Now, to me, the solution for this problem and the other ones I talked about is not complex. It really simply is just thinking about making a requirement for a scalable model with solutions that integrate into organizations. Now, these solutions have to be one, people, experts, and two, technology. And I think, relying and thinking about how technology can integrate as time goes on is really important. And both of these things, both the people and the technology, need to be focused and driving to provide not only rapid assessments, but also retaining or even optimizing as much utility as possible. And if we can do this, then we will reach that goal of trying to improve individual and society's health in the timeframes that Mark spoke about before, where you can be very fast. So as we move to the next slide, I think the one comment I did want to talk about is a relationship with Datavant. And as Mark had talked about, I think, there's a lot of pride in a lot of companies for the work that's been done in the COVID research database. And I think it's a perfect example of how people can come together to solve the risk utility challenge in a way that expert determination is not a bottleneck. And the solution has provided rapid, high quality research data, ensuring individual privacy at a time of great societal need. And it's a great example of how the ecosystem, in my mind, can come together, and how many partners, many who are online today, were a part of that initiative. And I think, to me, it's how people can come together to create something that has really rich data for broad access to help people in society. And I guess the other point in how we work with Datavant is we have a shared mission to try and streamline the process of certification. And so we work together in a number of ways to say, hey, how can we create some human-led automation tools for certification and remediation? But I think that's probably a future piece that we'll get to, later in the discussion. But I think at this point, it's probably a good time to turn over to Colin just to talk us through the expert determination in detail.
Thanks, Jamie, and good afternoon, everybody. From the poll that we saw a little earlier, there are people with a variety of levels of knowledge, so it makes sense just to get us all on the same page and cover some of the fundamentals very briefly. So in the US, of course, privacy and health information falls under HIPAA, the Health Insurance Portability and Accountability Act of 1996. So part of this act is concerned with protected health information, PHI, which HIPAA defines quite broadly to include past, present, and future health condition, but also healthcare provision and even payment. So that's really quite a broad church of different data sets that are under the scope of HIPAA. If data does contain PHI, then there are stringent restrictions imposed under HIPAA. But if data can be classified as de-identified, then it no longer falls under HIPAA and those restrictions are lifted. Of course, there are many uses for de-identified health data, even though it may lose some utility by being de-identified. There are still really good reasons for wanting to use it, which is really why we're doing what we're doing. So how do we know if data is de-identified? Well, HIPAA defines two ways. These are informally known as safe harbor and expert determination. So safe harbor is simply to remove fields. It allows modification of a couple of those, but it's essentially to remove fields wholesale that match a list. Now, there's no consideration of the data values in those fields, no quantification of the risk. It's on a field by field basis, regardless of what the whole data set looks like. On the other hand, expert determination has an expert assess the risk of the data and decide whether the risk of re-identification is sufficiently small. So expert determination then is, as the name suggests, it is a person, an expert, determining if the data is de-identified. A key point is that this is a bespoke analysis tailored to each data set. And the same information may be treated differently in different data sets, depending upon what other information is also present. So it's a holistic look at the whole of the data and the interaction between the different fields. So it may allow for different approaches to lower risk, depending upon the required utility of the data, and that utility may change for different clients. At Mirador, we tend to consider the inherent privacy risk independently of the security around it, and then let the privacy risk dictate what security is necessary, rather than the other way around. So for those unfamiliar with expert determination, I wanted to describe the way it typically progresses from our standpoint. This may help you as you interact with experts who are going to carry out this process for you. So a key part for us is to understand the data and the context around it. Who is the anticipated recipient? Who's actually going to receive this data? What is the use case? Is the data set static, or perhaps it's a regular update through a feed? What fields are there in it? Which ones are most important to the client? All of this information really sets the context for us to be able to assess the data in the most useful way for the client. If you ask most data scientists, they will tell you that the biggest part of data science is actually getting the data into a shape where it can be investigated. And that's true of expert determination as well. We may, for example, have to join different tables together by common patients. We may have to align the data to a provided data dictionary, perhaps take a random sample from a larger data lake. So this data preparation stage is really important so that we're working on the data in a format that makes sense. So there are then, broadly speaking, two approaches that are both followed sequentially. The first considers each field separately in turn. We classify it in terms of its risk to re-identification and look at the distribution of values. So a good rule of thumb is that rarer values contribute more to risk. So to illustrate that, imagine somebody is 110 years old. Now that age value of 110 is risky because it's relatively rare. Contrast that with somebody who's, say, 35 years old, much more common age, so that value isn't so risky. In so-called direct identifiers, all values are rare or relatively rare, so these generally need to be redacted. Indirect identifiers, however, tend not to be rare themselves, but combinations of them may be. So the next step is to consider those indirect identifiers. These are things that are reasonably available external to the data set. So things like age, maybe geography, that might be ZIP3 of the patient, maybe their race, etc. So what we do is we look at those and then we look at them in combination. And we try and quantify the risk that they contribute to the data set. Now, there are various ways to doing that, and they're usually based around counting the size of groups. How many people are there in groups that share the same information? So based upon that, we can then make a commentary upon how risky the data set actually is. And that may then lead to us making suggestions on how to reduce the risk. Now, there's usually more than one approach to that, which will be sufficient to make the risk low enough. And we can choose the one working with the client, which makes most sense for them. It might be, for example, that they want to preserve as much geography as possible. So we'd be looking to preserve maybe 3-digit zip code while perhaps losing granularity in something like age, for example. So finally, we would document all that we've done in a report, and a report that really can be written for internal use by the client. It could be quite technical, or maybe it's something that the client wants to give to their customers. So we can write it in an accessible way that makes sense.
Colin, before we jump on from the Expert Determination 101, we have a question from the audience that I think fits square into this. An audience member asked, does HIPAA specify who can be an expert or what is required to be an expert? Is there anything in the law that provides guidance on that?
Yes, it does, but it's not very specific in it. It simply makes reference to somebody who's got statistical and scientific knowledge of principles in the de-identification of information, but there's really no qualification. There's no scheme by which accreditation takes place. So while it gives some vague guidance on what that person should be and what they should do, there's really a lot of scope for working within that. I hope that helps.
Great. Thanks, Colin.
So moving on then, I wanted to go through some of the common issues that crop up that we find when we carry out expert determination for clients. So I thought this might help you in your interaction with experts if they're going to do some work for you, or really just to give a picture for other people that might be experts who are on the call, some of the things we see that might chime with you too. So we start with inadequate information. I said that we need context around the data. I would consider myself something of a data dictionary evangelist. I think this is such a crucial tool in understanding the risk within data. And I think these should always be accurate and informative. And they must be up to date. it's much better to have a description of the data as we see it, rather than how it was before some processing stages, perhaps redacted various bits of information. Unfortunately, it's not usually the case that a data dictionary is up to scratch. And that can cause problems. It often means some communication back and forth to the client, and ultimately a delay in getting to the report. Moving on to the next point.
Colin, if I may stop you for 1 second, we have another audience question that I think is perfectly on point here, which was, do you actually require a data set to perform the determination, or could that be done on a layout and a description of the fields and what is in the data set? Would that fall in adequate information?
Yeah, really good question again. Ideally, we want to see the data. HIPAA makes mention of statistical principles, which implies that we're summarizing a number of data values. However, if a data set is really quite simple, and just by seeing the contents of it, by looking at the data dictionary, that can be enough to comment upon the likely risk. We won't be able to quantify that risk, which we can do by looking at the data, but we can comment upon it in reference to the threshold that HIPAA sets. So the next point I wanted to raise was really there's often this lack of awareness how what can look a fairly innocent looking field, how it can really expose some risk. So an example here is NPI, the number that every healthcare provider will have. So it could be in the data, there is a field which is NPI number, and there might be a number 1, 2, 3, 4, 5, 6, or whatever it might be. Now that can be looked up externally in freely available information. And let's say we look that up and it aligns to a hospice, and it also gives within the NPI information the address and phone number of that hospice. Now, if that NPI number is relating to a particular patient, then maybe we've just found out where a patient lives through that NPI. The next point is representativeness, which is a long word and has an importance to match. If we're looking at only a sample of data, as is bound to be the case if it's a data feed, for example, then we need what we look at to be representative of the whole, so that our conclusions can be generalized to the whole data. That usually implies that we need some kind of random sampling to take place. However, very often sampling is done just for convenience, and there's always the likelihood that that's going to produce a biased sample, which may again cause issues when we're trying to quantify the risk in a meaningful way. The next point deals with the linking of two data sets. So if you're linking two data sets together and they're both considered de-identified, then the result will also be de-identified, yes? Well, no, not necessarily. It may not be. So by linking two data sets together, we're essentially introducing more indirect identifiers. And the more of these that there are, the more likely it is that we will have rare combinations resulting in perhaps uniques or very small groups. And they are what we term high-risk records loosely. So if we do link two data sets together, even if the constituents are de-identified, we must carry out a fresh expert determination to assess the risk therein. So to be de-identified, the risk of re-identification must be very small according to HIPAA. It doesn't say it must be zero. So that means within a data set, we may have some risk. And it follows that that risk is not uniform across the data set, but we actually have some records which are riskier than others. Now, what's important in HIPAA is that the overall proportion of risky records is sufficiently small. But that means if you take a subset of those records from a de-identified data set, you might just, by chance perhaps, or maybe by virtue of the query that you're making, you might just pull out a higher proportion of risky records. So high, in fact, that maybe that subset now has too high a proportion for it to be considered de-identified. Now that can be an issue if that subset is now exported as a data set in its own right. So again, what this implies is that we need to check those subsets, again, by expert determination. The next point is really just that some types of data are more risky than others. And that means there's a greater possibility of rare values. A good example of this is mortality data, which is often very granular, so it can be really quite high risk. And that means that very often to make a data set sufficiently small risk, we have to compromise on granularity elsewhere. So perhaps we lose information about location or dates, etc. So the final point I wanted to make is really relating again to when we have more indirect identifiers. It might be something that you consider to just have a single expert determination done on the whole of your data assets as one big data universe. But of course, there are likely to be a large number of indirect identifiers within that, which means in combination, we're going to have some really small groups, which means we're going to probably have to lose a fair amount of utility from that data universe for it to be able to pass the expert determination and be deemed de-identified. That means it's better to keep data sets smaller if you want to increase utility. And it would make much better to store those data sets in separate environments and do an individual expert determination on each, rather than thinking of just lumping all together just for the sake of perhaps convenience.
Great. Thank you, Colin. So I'm just going to encourage the audience and thank the audience for questions. Please keep them coming through the rest of the talk here, and we'll get to them in a moment. Again, thanks, Colin. Jamie, we'll now turn to you again. Given some of the pitfalls that Colin mentioned, we'd love to hear from you about some of the best practices that you recommend to your clients as you're working through the expert determination process. So Jamie, floor is yours. Thank you.
Yeah, that's great. Thanks, Mark. And I think it's really interesting seeing some of the questions come in. And I think, so from my perspective, when we're thinking about a certifier, it's important to think about the context of what that certifier is, right? So the certifier is an independent arm's length advisor and assessor who lives and breathes disclosure risk analysis and privacy in healthcare every day. That's the expertise that's coming to you. So then if you think, okay, how do we best work with that expert? I think what you have to think about is the expert doesn't know your data as well as you do. Well, maybe as over time, and that's one of the points we'll make that they do. But the most important point is probably determine first what your goals are. Think about what you're trying to accomplish with the data. What data do you need? What are you thinking about that you would like to have in that data? So what fields are important to you? How granular must that be? To Colin's point, it's very different if you're looking at zip to a 2-digit level versus a 3-digit level, or if you want to go even deeper. Just understanding how granular you want to be. And then I think at the same time, give the certifier a picture of what you're trying to accomplish. I think it's one of those cases where more information, not less, is best. And unfortunately, the less information or the more limited understanding that an expert has of the data and what you're trying to accomplish, the more conservative they have to be in their risk assessment. So therefore, what that would mean is you'd have less utility in the data. So having that conversation up front, and as Colin had said, generally centered around the data dictionary, is really a critical piece for success. And then I think the other part is work with an expert on an ongoing basis. That speaks to getting to know things, getting to know your data, getting to know your people, your processes, getting to know the environment you work in. And I think at the same time, it also allows some work together to say, hey, how can we do things that are most efficient for your organization? And so I think quite often we get into discussions around saying, okay, what solutions can we help with that integrate better into your business? Where does the determination process fit? How can we make things faster? How can we look at technological tools that could do some of the monitoring and representative checks that Colin talks about, or some of the checking of subset data? And so I think, like, in summary, it's a conversation. I think that's the most important part. Share as much as you can about what you're trying to do, have a discussion with the expert about what you'd like to have. The analysis happens, and then have a discussion around how do we retain that utility as best as possible. And I think if we do those things, that will allow for this smooth and efficient, expert determination process that can be as fast as possible, but at the same time try and retain as much utility, which helps you. It helps the organizations you're working with, and then ultimately it does. The thing that I started with is saying, what's the desire? It's to help, it's to help individuals and society's health. And I think those are the pieces that I think that every expert that's there wants to say, how can I work best with you to ensure that we get the most out of this data and that we protect privacy? And that's everyone's goal. And so with that, I'm sure we'll probably have some more robust Q&A, but I think we'll probably close and open that up, Mark.
Great. Thank you, Jamie. And thank you again, Colin. So yeah, we have some great questions coming in from the audience. Jamie, let me kick it off with one that we often see come up relating to the validity of a certification and sort of how long that certification is good for. Does it expire? Is it good forever? And a related question is, if you do an assessment on an initial data set, let's say a claims data set, and then tomorrow there's a new instance of those claims for patients that are going to be seen in the future, is that data covered under that certification? How should people think about new instances of data that's been previously assessed?
Yeah, I think there's a lot of discussion points just in those couple questions, Mark. But I think the time frame for expiry of a certification, I think there is no hard and fast rule. I think what's important is back to the comment that privacy changes, and people change their data. So the determination is very clear to say, here's what was assessed and that it's okay. And it also is very clear to say if anything changes. So if you add a variable, or if you're changing a data feed, depending on the kind of certification you have, it'll be very clear to say that it needs to be revisited. We typically find that needs to happen a long time before any expiration date occurs. Now, we typically work with a time frame of 12 months. It's in our experience to say you should be revisiting the data the certification 12 months from now if you haven't already, just to ensure that the external world hasn't changed, and then to verify that the internal world hasn't changed.
Great. Thanks, Jamie. Another question here from the audience. How does the actual disclosure of the data to the certifier for assessment occur? If that data is not yet certified for an expert determination, is there a business associate agreement involved, or how does that relationship between somebody who would be working with you work?
Yeah, another good question is essentially we treat all information as PHI even before we see it. So we have the security safeguards in place for dealing with PHI. So if the data is de-identified, then that's fine. We've kind of had more security than we need. But by taking that approach, then we're never going to be caught out by sharing information which may allow people to be re-identified.
Great. Another question from the audience about the methods used in de-identification. So there's a comment that some experts or certifiers will differ on how they view differential privacy, which for the audience is a method by which you can de-identify data by changing some values in the data set. So can we get your expert views on differential privacy and how that relates and may compare to sort of standard methods of de-identification, which is redactions and removing data sort of programmatically from the data set?
Yeah, so differential privacy is a very useful approach, and it's really for when you're querying a data set and you want to get some summary information from it. Essentially, you can think of it as just adding a small amount of error each time. And that amount of error should be small enough that it's not really going to give you some useless information, but it's going to be there so that you don't know the real answer, so to speak. And it also covers the situation where you're making multiple queries, one after the other. It's there to stop you building up a picture of what the truth is, so to speak. So there's definitely it's a really good method in many instances, but it doesn't fit everything. It's not always the right answer. And as I've kind of implied, there's error added there. So how it's actually working, how much error, that needs to be checked. So it's not like differential privacy, one size fits all. There are different qualities within there that needs to be checked. That might give rise to different experts treating it in different ways because they've actually seen different incarnations of it, maybe a good method and not so good method, maybe using it in a situation which isn't quite as appropriate as elsewhere.
Thanks, Colin. Another question from the audience. For real world data and data linkage used for regulatory submissions, are there extra steps that need to be taken or other considerations as part of the expert determination process?
So that's for regulatory submissions.
So in creation of evidence for regulatory submissions, is there any difference in the way that expert determination would need to work with respect to the data being de-identified?
If, as I said earlier, if the data is to be within HIPAA, then it isn't deemed de-identified. However, as soon as we pronounce it de-identified, then it's not subject to those regulations under HIPAA. So if HIPAA is something that is applicable in this case, then clearly the expert determination is going to occur in exactly the same way. We've done some work for organizations where HIPAA isn't the legislation by which the data is judged. However, they still want it done in the context of HIPAA because they tend to recognize it as being a very good benchmark. But if we're pronouncing data as being de-identified or not, then it's the same approach.
Great. We have a couple questions here related to automation of the expert determination process. And I think, Jamie, you mentioned in your talk that this is a human-led effort and the expert serves as the guiding person, but that there's tools and software that can automate that. So a couple questions are asking, how do you automate that? How much can be automated? And how do you get really fast turnaround times?
Yeah, all great questions, Mark, and all things that come back to the bottleneck discussion that I talked about. So I think our mission has always been trying to say, how can we look at ways to make the process as efficient as we can? So as we approach it from an automation perspective, I think HIPAA is very clear that an expert, a person, needs to be involved. And so we've taken the approach to say, how can we look at data in a different way and let the expert direct what's going to happen and let the machine support that in the simplest way? So I think if we just use an example, someone comes and says, hey, look, I've got this data set that I commonly use as a solution. And as Colin had said, look, there's the challenges of subsetting within that. There's the challenges that sometimes what happens is people don't want to send the whole data set. They want to take a subset of columns or a subset of rows to people. And a typical expert determination wouldn't cover all of that, or it could, but it would have a utility restriction. So instead, what we would do is come in and do an expert determination-like process, but then essentially create rules for every variable that the expert would be reviewing, create a rule set. And so then now there's a rule set led by the expert, very specific to that data that's sitting there, that anytime something wants to be used, it can be checked against the rule set. Now, we've written programs to be able to do that, to verify that what the expert expects to happen would happen. And so in that case, if it's positive, there's a certificate that's printed. If it's not, here's what's not okay. And then now the expert gets back involved. So essentially what we're doing is trying to remove repeatable tasks that the expert does that we know that the machine can do for us once it's instructed to do so. That's one tool, but there's other examples where you could do representative checks on variables of new information coming in, again, led by what the expert would direct those algorithms to run, and then verified at the end to make sure that it aligns with what the expert would say. So it's a pretty high level answer to a lot of very technological solutions that could come. But I think at the core of it is saying, how do we ensure that the expert is directing this process and then verifying it at the end?
Great. Thanks, Jamie. Another question here that may open a larger can of worms. So there's a question around HIPAA legislation and whether it's applicable outside of the US or whether there are other regimes and frameworks beyond the US, both for health data in Europe and abroad. So is there anything that you can speak to around how this or whether this applies abroad and how folks should think about medical data that they might have access to or work with that's not US based?
Yeah, Colin, maybe I'll take a start at that, and then maybe you can add some context to it. So I think what's important is HIPAA is a very US specific, law and regulatory framework. Other countries in the world, and we work with other countries. Predominantly, our work is with the US and HIPAA, but other countries have different frameworks. And ensuring that the understanding of those frameworks work for those countries or those regions that have those in place is important for that region. But then it becomes a bit of a challenge when you're thinking, how do you connect data around the world? Now, there's a lot of ongoing work, and we work with numerous clients trying to take a look at how to do that. I think what becomes an issue is there is some of the legislations at odds with each other. So HIPAA says, hey, it's okay to have some high-risk records. And that's why the experts needed is to say, is that sufficiently low? Whereas if you look at GDPR, anonymization is the key. And actually the whole de-identification process in the US is a very different approach in GDPR. And in GDPR, you have to say, hey, we can't identify anyone. And so trying to marry those two things together becomes very difficult. So from a GDPR perspective, the principle is only keep the data that you need to for that specific use. Whereas in the US, you keep as much as you can and try to be able to retain that data for time. And so I think it's the challenge of global organizations trying to think how to connect data together. I think what's really important though is from a disclosure risk perspective, the science is the same. Determining what the disclosure risk is for healthcare data is the same in different areas. It's how do you connect the regulations together? And Colin, I don't know if you want to provide more technicality to that.
I'm not sure there's a lot more I can say. Of course, within the United States itself, different states have different laws, some of which are more stringent than HIPAA, in which case they take priority within that state. HIPAA is kind of like a floor almost above which everything must be. Or if the state laws are weaker, then HIPAA is the one that takes precedence. I think the earlier question might have been the regulatory question might have been relating to sort of clinical trials, and they have a different set of standards in themselves. In Europe, we have the EMA, which is very specific about what anonymization should be, similar with the FDA. So there's a lot of competing frameworks here, I guess, and they do overlap, such that GDPR still applies outside of Europe if the information is held outside of Europe. It does become a very complex picture, and it can be difficult to navigate in a sensible way. So I can certainly empathize with anybody who has to deal with data from a number of different sources, different countries, and how you actually align those to come up with something meaningful that gives you utility, and you're still de-identifying to the required standards.
Thanks, Jamie. Colin. So I have a question for you related to the obligations of the clients that you work with. So for our audience members here that are working with data sets, you've covered the 101 of bringing in an expert, how to run through the process, the pitfalls to be aware of. And then once you get that determination, you have this data set that has been statistically assessed as de-identified and is now de-identified under the law. And then over the course of running the business, there will be processes where that data may flow across different databases. It may be used in different queries. And there's the possibility that sometimes rules that you might have prescribed or understood to be part of the process are not applied in future iterations of the data. So in those sort of situations, how should a client think about their obligations to continue to conform to that data set, or whether that determination, or whether once they have a determination, their processes related to that data set in whole are covered, or how do they think about that obligation and that liability there?
Yeah, I think it's important in this case that the actual report, which covers the certification, is sufficiently detailed that it does outline the requirements and when the certification is still valid and what takes it to be invalid. But I think this really makes a good case for what Jamie referred to earlier, which is that it's much better to have an ongoing relationship between the expert and the company rather than just the one hit, there's your data set, it's now certified, because they can be on hand to answer these questions. Hey, we're thinking of doing this with the data. How is that changing it? How's that moving the goalpost? Do we need to readdress it? Do we need to have another expert determination done? Because it can be very, it can be tricky to know in advance exactly what changes you're making to a data set by undergoing some kind of process. We've worked with a lot of clients who have some very clear ideas about what they want to use data for. But when it shakes down to actual planning the processes and putting the steps in place, then it can be a lot more intricate. There can be a lot more thought that needs to be given to the actual de-identification state of the data. I don't know if you want to add anything more to that, Jamie.
No, I think, Colin, you've really hit on what it is. I think probably the comment to add is, the work we do is not just expert determination. There's a lot before that, and with many organizations we work with, there's a lot of discussion and asking those questions ahead of time, Mark, to say, hey, we're thinking of doing this. Will that impact anything from a disclosure risk perspective? What do we need to think about? So it's that kind of design phase that we work with people, or just running analysis ahead of time, separate to an expert determination. So I think the expert determination is the output of what a lot of the work we do is, but it's not the only thing we do. Whereas I think, the focus probably historically has been on just get an expert determination versus having that discussion around how do we manage disclosure risk over time.
We have one question related to data breaches. So the question here asks whether if you have a data breach or an inadvertent disclosure of a data set, but that data set has had an expert determination and has been assessed to be statistically de-identified, what are the implications of that data breach? Is that still a de-identified data set and therefore outside the scope of HIPAA? How should somebody think about that potential scenario, and what, if anything, should be done were there a disclosure of certified de-identified data?
Yeah, this is a purely hypothetical question because it's never happened. So I think it may be more for a lawyer who might be able to, suggest what might happen in that case. But as far as I understand, it has never happened. So it'd be difficult to comment, really.
Okay. I think we have time for one or two more questions here. So we have a question also relating to regulatory frameworks on CCPA, which is the California Consumer Privacy Act. Jamie and Colin, I know we here at Datavant have done quite a bit of work around CCPA, so I have some familiarity, but do you have anything that you would share with regards to how CCPA thinks about de-identified health data and whether CCPA's regulations have any effect on the expert determination process for de-identified data on California patients?
Yeah, we've done some looking at CCPA. I think HIPAA now is, 25 years old. It's matured, and the wording, which some might say is rather vague, has come to be interpreted in a fairly standard way. I would say that most experts are aligned on that. With CCPA, it's still early days, and I think that wording hasn't really crystallized down to quantitative thresholds that everybody's using. I think we're getting there, and I think largely that HIPAA and CCPA may be leading us to the same place, if you like, and I think the standards may be aligned, but I don't think we're actually at that point where we can say that definitively yet.
I will add to that. I think your CCPA is not explicit about the requirements. It's similar in some ways to HIPAA, that there's a very small risk threshold that needs to be determined. CCPA doesn't have the expert concept, but I do believe there's a carve out within CCPA for HIPAA. And so that data is treated separately, both as an identified data set And then de-identified data under HIPAA would also meet the requirements of de-identified under CCPA. So that's my understanding and interpretation of what I've seen. So hopefully that helps that audience member. And if you have additional questions on that, feel free to follow up with us. So with that, I will turn to maybe my last question for Jamie and Colin, which is if the folks in the audience here have additional questions that we either weren't able to get answered today or anything comes up in the future, how should they get in touch with us? What should they do? Jamie, anything there, or just drop you an email here and then we'll.
Yeah, sorry, Mark, I couldn't find the mute button. I was too busy looking at the panel questions. Yeah, so I think, Mark, as you've already said, our details are there. I think it's very simple to reach out to us. We're happy to speak to anyone. I think the questions that come in, these are the things we love to talk about. So to be able to have a discussion with organizations to say, here's what we think, here's how we can help. We're more than happy to do that. So reach out directly to me. You can visit the website. There's also a web query through there. And we'd be happy to speak to anyone and continue the discussion, because I have been flicking through. There's a lot of great questions we didn't get a chance to get to. So I would be happy to follow up with anyone who submitted ones we didn't chat about too.
Great. Yes, I will emphasize that. For those who submitted a question, we see it, we have it, we will follow up with you. We have your information. So those who submitted live, thank you for the questions. And also thank you everyone for your time and attention. We really appreciate you being here and look forward to potentially working with you in the future. So with that, we'll wrap here. And thank you, Jamie and Colin, for the talk and the presentation.
That's great. Thanks, Mark, for hosting us. We do appreciate it. And thank you everyone for attending in your busy days.